Mark, you mentioned that comparison. I call it the bake-off,
Right.
that occurred at San Antonio this year. Do you want to tell the audience kind of what that was about?
Well, I mean, so they took the TransATAC trial and they looked at a variety of different scores, including, was that your IHC4 score?
No, it was the guy. It was the one. It wasn't our IHC4. It was the one that Mitch Dowsett did.
Right, and then I can't remember all the different ones, but things like EndoPredict, the 21 gene recurrence score, and they essentially saw how much incremental discriminatory capability you would get from tacking scores together. And you have the details and the facts and figures much more in your mind because I've seen you present this. But the bottom line is, everything added a little bit to everything else, and the question was which one added more in what circumstance, especially for the later recurrences, which were obviously a big issue for us because of the extended adjuvant questions.
It seemed to be when you look at that data, so the idea was the most fascinating part of that data, and I want to hear you guys' opinions about it, was when you looked at the data, so they had the IHC4 and what added to the IHC4 basically, and they had the clinical parameters, which are tumor grade, nodes, whatever, and then they see how much it added to it. And it was interesting, so the tests were 21 gene, PAM50, breast cancer index, which we're going to kind of talk now as we talk about extended adjuvant therapy in a minute, EP-Clin, which was EndoPredict. I think this was 4, so I think it was 4.
That was it. Yeah.
That was it. And so what they found was interesting. For node-negative breast cancer, all of them seemed to do really well, looking at 0 to 10 years of follow-up. So the 0 to 10 years of follow-up, all these tests did really well. For node-negative from 5 to 10 years, all of them also seemed to do pretty well. All right, maybe with the exception of the 21 gene assay did not do as well. Where the tests seemed to be really kind of starting to kind of fall apart a little bit, BCI did well too, actually. It was in the node positive. So in the node positive, really the ones that seemed to do best were ROR, was the PAM50, and EndoPredict. They seemed to do the best, so the EP-Clin. And in particular, they did best in that 5 to 10 year range, where BCI and the rest of them did very well for the 5 to 10 in no nodes. But the only ones that seem to really be discriminatory and find a group of patients that were truly not going to relapse for the node positives were the PAM50 and were the EndoPredict, the EP-Clin. And so it's really interesting because you follow that up with another piece of data where they did an analysis, they presented this at San Antonio, where they analyzed the breast cancer database with 75,000 women in it. And of those 75,000 women with node-positive, ER-positive breast cancer, 15,000 got a 21 gene assay for that.
Yeah.
So it's being used a lot. That's 15 or 20% of the population. It's being used a lot, and we're not quite sure if it really has discriminatory power in the node positives.
Right.
You know what I mean? So again, I'm really curious. This is kind of where we are in this world. I mean, do you have any final thoughts before we move on to the next topic, guys?
Well, I say, just to follow up on that node positive point, I mean, I think MIND-ACT and the TransATAC, because that included node positive patients, I think all of these actually make me feel a little bit better of sending the 21 gene assay and node positive. So the reality is we had a limited data set of, I think, 700 patients from Kathy Albing's study in which the 21 gene assay was validated and node positive. But that was all the data we had until MIND-ACT and the TransATAC data. So I guess I'm using it pretty widely in my node positive, 1 to 3 positive lymph nodes. And for me, the lack of precision in the extended setting for node positive was not all that concerning to me, because when I have a node positive patient who even though I just argued I'm not good at prognostication, for my node positive, ER positive patients, I am recommending extended adjuvant therapy if they're tolerating it and all of those things. So that's not as big of an issue as the node negative, where we saw the precision for extended adjuvant.
Right.
So 2 points, I think the extended adjuvant data node positive wasn't so worrisome to me from TransATAC. And 2, across the studies, I think we're seeing a consistent signal that these genomic predictors actually do work in node positive. They at least are prognosticating in node positive. Whether or not they predict chemotherapy remains to be seen.